name is Human Relations Application
Thank you very much. I welcome you all to this meeting. It is our first formal meeting with the Commission, and we're expecting to hear a lot from you, but also be sure there is a lot that you'll hear from us, being our meeting, and especially after so many events have passed. I welcome you from the World AIDS Day. I welcome you from ICASA and congratulate us all as team for winning that bid in Rwanda, because those who were there know what exactly transpired. But I want to welcome you back and thank you for putting up that strong fight as a team. The committee is conducting this meeting in accordance with our rules of procedure, which requires you, AC, to keep updating the committee on the AIDS activities and situation in the country. I'll request you to note this, because when we come to the reactions, I'll leave the members to contribute. This will be from me. We have $1 initiative, and we're talking about the AIDS Trust Fund. We shall ask our commission to give us feedback on what they got as results from their benchmark trips. And then 2, we have a well-structured and coordinated civil society, and we've had engagements with them. But we want to hear what UAC has got as activities in the whole country as a follow-up on their activities throughout, because you have the mandate and the role on all the HIV/AIDS activities in this country. Then 3, we have growing attacks on key populations. Yes, there is progress by the ministry, especially the minister, but we need to talk about strategy on how we are going to handle this. Instead of attacks, how else can we handle this? Especially that number 4, Uganda is hosting ICASA 2021. How prepared are we as a country? We're expecting the commission to tell us, since you have the sole responsibility, what will be our source of funding? And how do our implementing partners come in? On the same, how do we make this more inclusive and participative? Then on the same, lastly, what are the best practices learned from the other countries that have hosted ICASA? Then 5, on coordination and governance funding. It is only about 10% of the districts in Uganda that have got the AIDS committees. And surprisingly, about 1% of them are operational. And I think it's causing questions to the development partners. They're asking, how has UAC institutionalized itself? How have you taken strength in the districts? If only 1% of only the 10% districts having AIDS committees. And what is their role? We have got we have got new tools and frameworks out there in the field, like the test and treat and others. How have we organized a multiplayer monitoring visit or test on these current tools and frameworks? What is the feedback? Then lastly, 6, access to information, true and accurate information. Other than the PFTI, there's an outcry that when we ask information in the current situation on AIDS in the country, may be a lie, but a speculation also, that the only flyer that we give out, or the main flyer that we give out, is PFTI. So we as a committee will request Uganda AIDS Commission to help us settle with these asks that we have put before you. And as I rest my case, I'll ask also that we are expecting, or we've been expecting, at least a few strategic briefs from you and asks really on us as your partners in this fight. But we have not got any. How are you doing that? Are you doing it with any other member of parliament other than the committee? Or how have you done it with us as a parliament that is supposed to be working with you? I thank you. I will now ask that USC gives us what they had prepared for us. Thank you.
Thank you, Honorable Chairperson, Honorable Florence Namboso Wama, honorable members of HIV and other related matters. It is indeed a privilege for us to be here today to interface with you and have some very, very fruitful engagement. Permit me to thank you for inviting us to interface with you today on HIV situation in the country. We will address specific areas of progress made as a country, key challenges and recommendations as we move towards the epidemic control of 2030, and indeed throw more light on areas Honorable Chairperson you've raised. First and foremost, as the Commission, we appreciate the technical oversight and policy development provided by Parliament, particularly the Hiv Committee and other committees like Health and Presidential Affairs. Following the launch of Presidential Fast Track Initiative for Ending AIDS as a public health threat in Uganda, we managed to rejuvenate the HIV stakeholders in the country through regional and district-specific engagement. I refer you to the annual Presidential Fast Track Initiative report that has been enclosed in your documentation. Currently, we have embarked on the development of a new HIV National Strategic Plan for the country, which starts 2020-2021, and this will end in 2024-25. This will guide the national response towards epidemic control and aid proper planning and resource allocation in the country. The Uganda AIDS Commission has finalized the development of the national HIV regulations, which is soon going to be put in the government gazette. The regulation is derived from Uganda AIDS Commission Act. This would help improve the coordination of HIV actors in the country and alignment of the implementation of HIV and alignment. Yes. Yeah. The Uganda AIDS Commission has finalized the development of national HIV regulations, which is soon going to be put in the government gazette. The regulations light from Uganda AIDS Commission Act. This would help improve the coordination of all HIV actors in the country and realignment of the implementation of HIV interventions in an equitable manner throughout the country. Honorable members, all the detailed areas requested on HIV financing, HIV sustainability plans, preparation of a CASA, my technical team that's led by Director General is going to present to you now. And once again, I thank you for the selfless effort you have rendered in driving the HIV scourge in the country. For God and my country. Chairperson, Uganda AIDS Commission.
Thank you.
Thank you, Chair, and thank you, Chairperson and members. I apologize again for coming late. It is not in my habit and practice, and my team knows that I'm quite stringent with timekeeping. I've been unwell. I had gone for a retreat with a team. We are trying to prepare the HIV paper to feed into the NDP3. We're in Entebbe, and on Saturday I started feeling unwell. On Sunday it became worse, and when I went to the clinic, I found that I had very high levels of malaria. So even yesterday I was in office. But this, given its importance, I knew that I had to be here with the team. So that was partly contributing to my delay, and I sincerely apologize for that. I have shared, and again, I'll later on make also an attempt to comprehensively respond to the chair's comments and questions. It is true that she had requested me for the commission to come and share an update with this committee, and we were in that process, but she has written and said we needed to appear. So again, we didn't make a timely response to that request, and the issues that she's raising are pertinent, and I hope we can get guidance and have a probably proposed schedule in terms of we expect 2 or 3 interventions or quarterly interventions, and they can be at this time. Maybe we can work with the clerk to the committee and have that timetabled, and then we do not fall into the same, where we come when there is real pressure and need for this information to be shared with you. So I've prepared a PowerPoint presentation that has been circulated, and we'll focus on the areas that have been requested by the chair and the committee members. They include, I'll say something very brief about the mandate of Uganda AIDS Commission and the strategic objectives, and proceed to talk about the status of HIV and AIDS in Uganda. I'll also speak about the domestic and donor funding status on HIV AIDS in Uganda. I'll speak about the sustainability plan for funding the HIV AIDS response, and then speak about the preparations for the CASA 2021. And then I'll add a brief on the implementation of the Presidential Fast Track Initiative to end AIDS as a public health threat. And then after that, we can go to specific questions that will arise out of that presentation. So, Honorable Chair and members, the mandate of USC as per the Act CAP 202 is to coordinate the national multi-sectoral HIV response with emphasis, because we see ourselves as a home for the HIV prevention component. We have different stakeholders in the country working on different components, and especially the Ministry of Health working on the public health response, what is known as the public health response, puts in place the health facilities, ensures that people are treated. But we are responsible for policy, for strategy, to ensure that everything is being done, but ensuring that prevention does not fall on the side. So for us to be able to do that, we've set up in our strategic plan that is going to end June this year, and we are in the process of starting another one. We do that by enhancing advocacy and communication for the national HIV response. We would like to improve HIV/AIDS strategic information for evidence-based decision making. There is a deliberate effort to strengthen governance, leadership, and management for HIV/AIDS response.
Excuse me, DG.
Yes, Chair.
Sorry for interruption. May I invite you to have that tea in front of you? Just don't look at it. It is served for you. Thank you. Please go on.
Thank you, Chair. I had already started without the invitation.
As well.
Thank you. And then to mobilize adequate resources for national HIV/AIDS response. And if the points that the Chair raised as questions almost fall under each of these, because she has asked questions on communication, she has asked questions on information, she has asked questions around coordination at the sub-national level, which is governance and leadership, and she has asked questions on resources. She also asked, the letter talks about the presidential fast track, which has 5 points, and the 5 points also are aligned to these 4 strategic objectives that are raised on that page. On the next page, Chair and members, I would like to proceed to now share the status. I've shared an A3 historical perspective in the file. You can go back and look at it. It's very interesting history, but we've sat with partners and mapped out. And it is thought that actually the first HIV cases may have been seen in Uganda in 1968. If you look at that timeline. You look at it later. I wouldn't want us to go there, but when you look at it, there's a description of a couple in Makindye in 1968 where symptoms were described and it was being referred to as Lyme disease, and we are following this up very closely. Then in 1978, President Amin, spoke in public about, a strange disease that had been brought in because of, people coming from across the border. So interesting timeline up to where we are and looking at where we'd like to go, because we think if we are going to defeat the disease, it's very important to underline, the history and where we've come from. But Chair, just to come back to where, as a country, we actively got engaged. If you look at the literature in the 90s, this epidemic was in the general population was recorded at 18%, but in specific, most at-risk populations, 4 in every 10 people, were found to be HIV positive. But because of the leadership at the time, actively engaging, because in the 90s we barely had medicines for treatment. Prevention was the mainstay. By 2005, the HIV prevalence had been reduced to 6.4%. But this, again, good things always come, they have the other side. So when treatment came, it looks like there was a laxity. When a study was done later in 2011, the prevalence was found to be going up, and that was at 7.3. So a re-emphasis had to be made again to say treatment alone is not a solution. We have to have a combination of both prevention and treatment. And the 2016 results indeed showed that we were beginning to have, an edge over the epidemic, because the results showed 6% prevalence within the general population. The next slide has 2 maps of comparing 2011 and 2016, but showing prevalence by geographical region. In fact, USC is working with the Ministry of Health, and soon we will share with you results by district. We'd like to, currently districts by themselves can only show positivity rates, which is not an accurate reflection, because positivity rates show people who are coming to the health facility. But those who are not able to come because they are feeling well will not know that they are HIV positive. But our teams have worked and they are trying to show, they will be able to show prevalence and the new infections by district. And that way, you're able to follow up and say which sub-county is most affected, what are the underlying factors, and how can we go around that. So that's the beauty of breaking down statistics. But this shows where the burden is concentrated. You can see that, the region around Lake Victoria remains highly burdened, while the regions of West Nile and Northeastern are still the regions with the lowest infection. But also the second factor to note between the two maps is that generally there was a reduction in HIV prevalence between 2011 and 2016, except for the Middle East. If you see the Middle East, in 2011 the HIV prevalence was 4.1%, and in 2016 the HIV prevalence was 4.8. I'm sure the chair is well aware about this statistic because at the previous World AIDS Day, this was again emphasized, and but this tallies with other indicators. If you look at the school dropout rates, if you look at teenage pregnancies in that region, and other underlying drivers of the HIV epidemic, you see that they are tallying. So it tells you why, and therefore the things that we need to do to ensure that this doesn't happen again. Chair, in the next slide, on page 4, which is slide 7, we are talking about our efforts, that Uganda is among the top 3 countries globally that achieved one of the highest reductions in new HIV infection. We had a target of 75%. We wanted to have new HIV infections reduced by 75% by 2020. And that was a global target set by UNAIDS. But this, Uganda had a reduction of 40%. The global average is about 15, many countries. So this is an area that many countries struggled, and the global average was 15. We also did not achieve the target, but we did much better than most of the countries. But the emphasis is the next bullet, that we can't just celebrate those results because we remain amongst the top 10 countries, the highest burden in the world. When you look at our population now of approximately 42 million, we have about 1.4 million people living with HIV. About 1.2 million of those are on ARVs. So those definitely know their results. We have another, 50 to 60,000 out there who have tested, but they are not yet on treatment, probably still trying to make up their mind. So that's a risky group because they know they are positive. If they are adults, they are sexually active. So the likelihood that the infection is passing on is high. But there is another proportion of about another 150,000 who are not aware of, who haven't tested. And they are also out there whom we have to find. So the Ministry of Health is working with partners to deal with that. But when we computed the new HIV infections, for the 2018 data, we were telling you the number of 53,000. We've had a reduction, but not very significant, because when we computed the results by end of 2019, the new infections have reduced to 50,000. So not as many as they were in the previous year, some progress, but not good enough progress. And the AIDS-related deaths have also reduced from about 28,000 people dying due to AIDS-related deaths to about 23,000. Again, we try to compute that, break it down between men and women and children, but also compare to, because, health-related deaths are occurring in different parts of the country, doesn't present a very dramatic picture, but you can imagine if this was a road traffic accident or a plane crash, then it becomes a national disaster and can draw a lot of attention. And that's why we are converting some of the statistics to kind of try to bring the picture closer. So because of, the apparent slow progress, not achieving the targets, in 2017, the president launched the Presidential Fast Track Initiative to end AIDS as a public health initiative, as a public health threat. And indeed, Parliament has been part of it. Like the chair said, we are the chair USC said, we are very appreciative to Parliament. when we speak like this, it doesn't show enough how we appreciate the support we've received from you. We moved around the country, and at each of those meetings, we had no less than 15 members of parliament. Very often, almost all the time, supported, you didn't receive any support from us as USC. In fact, at some of the meetings, this committee extended support to us to be able to meet some of the things that we were doing at all. So we are very supportive of not just the oversight role that you demonstrated, but also the support. You came in, you did the physical visits to the health facilities, you gave reports, you interacted with the local leaders. They were I could see visibly, the chairpersons of the districts, the mayors interacting with you, presenting their issues, and knowing that the issues are reaching the place where they will be dealt with directly. That was very powerful and moving. And programmatically, we saw that reflected in the results through people who are going for testing, and groups were having challenges with men. So below in the next, the 90 targets that we had set with UNAIDS. Usually we evaluate this by end of the year. They follow the calendar year, so the final results will be computed in December 2020. But as we speak now, our results are at 89% of people living with HIV now have tested and they know their results. 88% of those who know their results are on ARVs, and 83% have achieved viral suppression. So we are not doing so badly in terms of the target for setting the target for 90. The next slide on page 5, Chair, is talking about HIV/AIDS funding analysis, looking at how much the donors are funding, what the government of Uganda is funding, and the private sector contributions. It's not in color, so it's not a very, in terms of visuals, not very well visualized, but it looks at the years 2017-18, 2018-19, and 2019-2020. And basically what you can conclude from this slide is that we, as a country, the HIV/AIDS response is still predominantly funded by donors. Through the 3 years, you can see, although their funding has reduced slightly from just over 80% in 2017-18, and the figure for 2019-2020 shows that they are just above 70%. The government of Uganda contribution has increased, which is a good sign. It's a small figure, but I think we need to celebrate success, however small. And government has increased its contribution from $61.8 million in 2017-19 to about $103 million in 2019-2020. This contribution may not necessarily bring in everything, because a lot of this support would not function if we don't have the infrastructure. We've not costed, support like this that we receive from you. We have, health professionals in those facilities paid by government of Uganda. They don't just treat other conditions. They don't see other patients. They're also, supporting HIV. So there's a lot of support not captured here. We've mainly looked at, direct monetary support that we computed and inserted here. So when we see these figures, probably if when we are discussing with partners, we raise this, all the time, that we could be underplaying the government contribution. It's not as small as what it looks, because if you brought donor support, even if it's $1 billion, and you don't have people to administer the medicines, you do not have places where this should be done, you will not use the money. The money will go back. So this picture needs to be interpreted in context. The second slide, Chair and members, is talking about what is the sustainability plan.
And for giving us reason to go back and read the documents that you presented to us. I'm sure honorable members have been alert, and at this point I will let them chip in for clarity wherever necessary, because I gave in mine, but I request that honorable members come in, then I'll give in mine at last. I thank you. Yes, please.
Thank you, Chair. I want to thank the Director General for the presentation. I have a few issues, but to start with, I want to thank Uganda for getting the opportunity to host a Kasha. My only prayer, Chair, here is that I believe the National Organizing Committee is in place, and that committee should do everything possible. I also believe the committee on HIV in one way or the other will be involved, so that we really try to show to the world that we can host other functions. Uganda has hosted other international functions, but of course there are also other areas where we have not done very well, particularly where it involves sometimes specific areas. So I think the National Organizing Committee should pay attention to every nitty-gritty of whatever is supposed to be done to ensure that the function is organized properly. Chair, on page 2, when we look at the strategic objective 2, the Commission has the mandate to improve HIV strategic information. I'm happy the Director General talked about it. Through matches, many people have received the information about HIV countrywide. The issue of having some of these fact sheets translated in local language is still a big challenge. You mentioned that, but I think people need information because HIV and AIDS, particularly those of us in refugee hosting communities, really have so many people who are positive living, and it has taken sometimes to our individual initiatives as leaders. Of course, it is our responsibility, it is a joint responsibility, but I think there's something which we need to do on that, because when we had the HIV Skull Show High, I was not a member of parliament, but I was working with the World Vision, where we formed the sub-county AIDS committees. And that group helped us so much. In fact, up to date, our committee, even at county level, for the HIV is very strong, because they were being sensitized, and their chairperson is somebody who has lived with HIV for more than 20 years. So every year, even this year in Uganda, we send them to attend the National AIDS information. That's when they only get some of these packages which are given. So I think we thank you for that, but I think we need to do something on that. And on the strategic objective 3, there's the issue of strengthening governance, leadership, and management systems. Just as the chair had put forward, at the district level, most of these committees are not active up to sub-counties. So it has really affected that kind of organizational level of those committees, who should in fact be reaching the people. Then on page 10, we have the sustainability plan for funding HIV and AIDS. I think I want to thank Uganda AIDS Commission for outlining those, but I think as members of the committee, we need really to request the government to increase that funding. When we look at the donor funding vis-a-vis the government, one will imagine if the donors pulled out now, what will the situation be like? And of course, there are so many circumstances where we have the aid cuts and what have you. So I think I really see that the most important thing here is to see that the government of Uganda increases the budget, but we are happy that our president is positive. I think we shall advocate for that. Then the other issue is on the critical unfunded priority. Particularly, my concern is with the wage and the allowances, which is number 2 on the last slide under the critical and funded priorities. I don't know what is going to happen because if those people, if there's no wage and allowances, are we going to close these offices in the districts? Because it is one area where I see really something has to be done. Thank you, Chair.
Thank you very much. Before Honorable Waza comes in, the members who joined us while we are at it, I kindly request you to introduce yourselves to the commission team. Use the mic, please.
Thanks so much, Chair. My name is Doreen Ruth Amule, woman member of Parliament representing Omolda District to the 10th Parliament of Uganda, and I'm also Chairperson, Defense and Internal Affairs. Thank you.
Any other member?
She's asking me what I'm doing here. I'm a member of Hiv Committee.
Yes, Honorable Azza.
Yeah, thank you very much, Honorable Chair. Once again, I'm called Aleritom Azza, a member of HIV Committee. Dear members in the House now, there is this paper here where it's written HIV/AIDS through the years, and where we went historical, that in 1979, 1978, President Amin referred to AIDS as a funny disease brought by the soldiers from Tanzania. Dear members, I also feel a similar scenario can present itself by the SPLA from the Sudan. Tanzanians brought from Tanzanian soldiers brought from Tanzania. Then I also fear, my fear is that also the SPLA soldiers from the Sudan will bring it to West Nile, because they form a part of the refugees. They are moving all over the whole of West Nile region. So please take note of this, that really the soldiers from the Sudan can also spread HIV and AIDS apart from the refugees themselves, both in the urban areas and also amongst the host communities. Right now, according to the papers here again, HIV prevalence rate is 4.9%. I don't think that this is going to increase because of the refugee factors. This is very, 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 very important. The refugee factors will really be put into mind as we are fighting the HIV and AIDS cause. Secondly, the chair asked about how UAC is entrenched in the districts, and again, and especially in West Nile district that are hosting refugees. Don't you think that, as it has been pointed here on page 7 on the slide, I want to draw attention to page 7 about stakeholders engagement. That's where it said all district leaders, oriented LC5s, the chairpersons, the cows, RDCs, DHOs, focal persons, DCDO, and so on and so forth. All urban leaders, and so on. Cultural leaders, young people, the media. I, for one, will feel that really this will be taken up seriously so that we can have all the districts in West Nile informed about the issue of HIV and AIDS, so that we can at least work in order to try to prevent it. Then lastly, when you come to on page 16, okay, at the back page of this same document, the last page, about critical unfunded priorities. Critical unfunded priorities. Again, I want to draw your attention to the issue of refugees, where you have said, engage cultural and religious institutions, reaching out to young people in and out of schools, fishing communities, refugees, HIV and AIDS, prevention and stigma reduction messages in line with the PFTI objectives. So this will again overemphasize about the issue of refugees, and since this is really under critical unfunded priority, I don't know what they're going to do about it, because we need money really for moving in the midst of both the host communities and also the refugees. And lastly, on page 13, page 13, why is there a decline in the grants received from donors in the period 2019 to 2020? Because if you can check on the table here, 2017-2018, there was 980 million. Then when you come to 2018 to 2019, it came to 3.3. Then 2019 to 2020, again it came down to 2.7, something. What exactly is happening, and how are we going to address this? Why is there a decline in the grants by the donor communities received by USC? Thank you very much.
Thank you, Honorable Waza. Yes, Honorable Doreen. Kindly use your mic.
Drawing from the privilege that you are sharing with us, I think something that I always observed in my community as well. You know, I come from a fishing community, but my interest basically is on two areas. That is men who have sex with men, and also we call them homosexuals, I think, and also maybe not to categorize, we can say those who have same sex, and then the children born with HIV/AIDS. What effort are we having in place? Let me start with the children, because time comes that they leave the childhood, they go into adolescence, and they become mature people of age. And when somebody matures, definitely people have a thought of getting married and so on. I've seen two scenarios which were really very painful in my community, where a girl nearly wanted to commit suicide because she felt like she's any other human being who would want to get married, but with the condition of having HIV/AIDS, nobody would walk freely to her. And I think the people who would perhaps want to approach her are these elderly men who are also positive, and they would think of exploiting her, more or less exploitation because of her status. How do we always handle such scenarios, and what information can we have and share so that when we are confronted with such some challenges, we can be counselors among very many counselors that we have. And also this group of people that the president admits we had them before and we still have them. Do we have any other, what I would think, a secure way of helping them come up and say, yes, this is what we are, maybe not in the domain of public health, that they may not easily be accepted? Is there a provision for us? Is there a mechanism that we're designing? Because one biggest risks with this kind of people is, much as they have these behaviors in them, at a certain point they also go interact normally with other people, because one can be an homosexual and yet has a wife. One can be an homosexual and yet has a girlfriend. Or one can be a lesbian and yet also has a boyfriend, or such things happen. So that means if we don't have a mechanism of dealing with them, just like we are trying to bring up a way of helping the adolescents or the young person from exposure that they normally fear, we are also endangering a certain group of persons. Thank you.
Thank you, Honorable Doreen. Any other members? Yes, Honorable Robina.
Thank you, Chair. I'd like to thank the elaborate and clear presentation from the UA Journalist Commission. I'm also concerned about the statistics. Slide 5, you talk about the percentage, the current 6% in 2016, and we are in 2020. Statistics of 2016 and the way the population of Uganda is growing and the way younger people are very vigilant and the way they are fighting for their rights to have sex at leisure and to protect them so that they can have sex at whatever time they want. So I don't know which current information in terms of statistics you can give us. Because even on slide 7, when you mention about the 50,000 people are getting new HIV infections annually, and as we have been here more than 12 people, I think we have been here about 2 hours. More than 12 people have got infected now with HIV. How do you come up with these statistics as we speak now? Then the other one is about the interventions. The member chair asked about the specific interventions for Uganda's Commission. Have you amalgamated your interventions within the presidential fast-track initiative? That what is being implemented as the presidential fast-track initiative is the work for, is entirely the HIV/AIDS work for Uganda's Commission? Because I know the districts are reporting on these issues time and again. Chair was talking about the vigilant work of civil society, which of now has also reduced because of the presidential fast-track initiative. Civil society is also pulling back from being implementers of HIV/AIDS work. I remember we used to have a lot of home-based care programs that we are good to follow up. Even this percentage that you have on the 90, because you still have a certain percentage that we are still fighting with. 21% still don't know their HIV status. How do we reach them? Because having 21% who don't know their HIV status, with this number of 60 people getting infected every after 1 hour, if you try to multiply, we are going to be struggling, because as we say now, we are saying we are doing well as Uganda, but we are still badly off. So where are we? We are doing well at a certain level, but we are still badly off in terms of the infection. So I would like to know where Uganda's Commission stands as far as those issues. I rest my case.
Thank you, Honorable. Honorable Secretary.
Thank you, Honorable Chair. Thank you, ED, for the explanation. One, I would like to get clarity on the savings that you talked about and versus human resource in regard to generics and brands. I would like to know more about it. When you look at what you're talking about, the mainstreaming, I'd like to know whether you have made a follow-up or support supervision under these MDAs, like UNRA, URA, and the rest of the department, to see how they are implementing the HIV mainstreaming in their departments. and you have reports could be to share with us. When you look at the districts, the chairperson commented about it, the district AIDS committees and the sub-county AIDS committees, they always get money for HIV activities. But I would like to get a report from you, whether you have been following up to know whether these activities are implemented on the within various districts and sub-counties. We got a delegation from Nordic countries. These were countries, our delegates from Denmark, Norway, Iceland, and Sweden on 11th Feb 2020. And we were told from that meeting that we are going to get an addition of 100 million USD. Is it captured within your report, or you are relying on the other information from last year? Because this money was pledged to start in the next financial year, 2020-2021. So I would like to know whether you included that pledge that we got on 11th Feb. Thank you very much.
Thank you, Honorable Joel. Any other member? Thank you very much, members. That is an implication that you've been listening. I'll add on mine. DG and Chairman, as the top management at USC, I have been at meetings that are involved in ending HIV in this country. And for us, we look at you as the topmost body that is handling our activities. And I have not seen your representation there. I have not seen you participating in these top HIV eradication meetings. I'm wondering where you are, because they've asked me and I've told them I'm from Parliament, not USC. Key populations. We're going to hold ICASA, and those who are in Rwanda, you know what was happening. How prepared are we as a country? Because this requires a lot of sensitivity. If we are going to hold these numbers, the expected participants are 10,000, you say, DG? If we are going to host our 10,000, say plus, or a little less, how are we handling this key population issue? Because it's very key. There are so many speculations about Uganda as being so opposed and insensitive to key populations. And we as a committee are looking at that as maybe a negative catalyst to our conference. And lastly, as a chairperson of this committee, first of all, this year, Bugis is holding circumcision that we all know that is a very good catalyst for HIV. I do not know whether to call it a request or a point to put to you to think about, that these members of this committee, you clearly mentioned that we have been working together and in support. We request that you have health camps as a backup of this fight against HIV. And with that, I request that we have one in Bugisu soon, because the circumcision is already taking off. And you know what it entails. It brings so many people together, it brings youth together. It has got 3 months of precursor to the main launch of the circumcision period. And these people are in one place for 3 months. doing festivals. They are drinking, eating, and making merry of every sort of activity. So I pray that we plan an activity in Bugisu, because it does not only host Bugisu, but this nation as Uganda, and we as frontliners in the fight against HIV must be at it. And lastly, the condoms. That went bad. We have not had a communication from USC, official communication. This nation has been waiting, but we as a committee, we are waiting for you, our main body, to speak technically and professionally to us so that we take back to the nation. I thank you. We now await your responses. Please use your mic.
Thank you, Chair. I'm saying that with my chairman's permission, I'm going to assign questions. He's at liberty to answer any question, and he may speak last. But I will ask that the question that was asked by the Honorable Chair of the Defense Committee on Homosexuals, Adolescents who are becoming sexually active. Dan, please prepare to answer that question on HIV prevention. The question from, he's not with us. Where is he? Okay, I will answer it if he's not back by that time. The question from Honorable Robina on data, DPSI, Dr. Bagambe, please answer that question, because what she's asking is this information, where is it coming from? Is it accurate? Is it up to date? There is a question on specific interventions for USC being separated from other interventions, especially under fast track. I'll respond to that. There is a question on clarity on savings, generics versus brands from Honorable Sevikali. I will also answer that. The question on HIV mainstreaming, have we followed up with UNRWA, URA, and others? I would like, again, Dr. Bagambe to respond to that question. The question on functionality of district AIDS committees, sub-county AIDS committees, how the activities are being implemented. I would like Director Partnership to respond to that question. The question on NADIC, I will say something about Nordic members of Parliament and their pledge. I'll say something about that. Our missing in critical meetings, I think that's also the chair. You can say something. I'll add on to. It's a concern she raises. The question on KPIs, again, how shall we handle it? I think both you and myself can share, and then we get your own input, and then there is the pledge to support the Bugisu question. I thought there was a question on the budget. Oh yes, there was a question on the declining budget. Why, we see the donors' budget declining over the last 3 years. I would like the Director of Finance to respond to that question. And I will come in to back up on any of the questions, because Chair, the reason we move as a team is for us to share responsibility, but for you to also see that this team just doesn't escort it, actually. it shares in the work that we do jointly. So then the organization towards the setting up of a national organizing committee, and whether, again, there are proposals that we've not even tabled to, because it's a complex process. We are making sure that we have concurrence and consensus as much as possible. But there's a proposal of a NOC, that should have all the national institutions, including, parliament, the different ministries and departments. In addition, because the ICASA people are mainly proposing technical committees. We've looked at it, but we also want to use our experiences as Uganda. And we know that, for instance, you can't run a successful conference if you don't have Minister of Foreign Affairs. Now we know we have, we have to have Minister of Internal Affairs for security issues. We know our Uganda Tourism Board and the Minister of Tourism. We have to work with Parliament because you've just concluded a major conference where you hosted, parliamentarians in the country. So the committee, we will, again, this concept, before we finalize, we will have you make your input into it. But we don't want to put the country to shame. A conference for 5 days hosting 10,000 delegates is a really, really huge affair. And we cannot pretend that that we will do that alone. The Honorable, I think, went up and raised several other questions, including translating information into local languages, which we've started working on. He talked about the critical unfunded priorities. In fact, our Karamoja office, and maybe he will touch on it, our Karamoja office is currently being supported by funding from Irish government. This funding ends in December 2020, and that's why we are including this to Minister of Finance as our funded priority. It will be a disaster for us to close that office, given that the work with, because our absence from that region was making coordinating HIV activities very difficult. The stories of the girls, returning from Kampala and Nairobi back to Nakapiripiri, and the HIV prevalence in that region because of that. So it's very critical. But we also want to enhance our presence. In addition to being in Gulu, Moroto, and Mbarara, we'd like to go to other regions of Uganda. So that's why we have that budget line. We have HIV focal persons in districts, but they are doing delegated functions. So in the absence of funding, they go off and do other activities. But if you have people closer to them in the regional offices, then they support those individuals. Honorable, you've raised an issue of the SPLA from Southern Sudan, replicating this information is for us to interpret. Of course, President Amin made public comments referring to, the Tanzanian story. It may have been related. Actually, evidence shows that Southern Sudan has very low HIV prevalence. And it is related to the HIV prevalence in the West Nile region. And we think that it is highly associated to the cultural practices of that region. It's very different from the other parts of the country. I am not saying we shouldn't worry about the influx of refugees. I think we need to have a lookout for it, because migration is a risk factor for HIV transmission. When you move away from your partner, sex doesn't stop to be a need. So for us, when we are planning in the strategic plan, we know that, for instance, the reason we focus on infrastructure projects, we know young people are moving, they go and stay on, whether it's construction of a dam or a road, they're away for 6 months. They're interacting with the local communities there, and that's how the HIV transmission takes place. It's the same for the refugees. So we will pay attention to that aspect also. I think let's continue. And Dr. Mugabe, do you want to respond to the questions on information?
Thank you very much, Chair. I'll start with the question about the statistics. It is true that the statistic that we quoted was last done in 2016 and 17. But if you look at the statistics that we made reference to, these are incidence and prevalence figures. So these are figures. Prevalence is, you could say, the percentage of an infection present in the community. And so the best way to measure it is by conducting a population survey. But given that population surveys are expensive to conduct, we usually do this every after 5 years. We last did the Uganda population-based HIV indicator survey in 2016, and the report first results came out in 2017. We are now in the process of conducting another population-based HIV indicator survey in December 2020. So when we get the results for this survey, we'll be able then to have an updated prevalence figures. In between the 5 years, what we normally do is we use modeling method, and then we are able to have estimated figures. But we cannot estimate the incidence or the prevalence. We can only estimate, for example, the number of new infections, the number of deaths, and if you see, using models, we are able to have an estimate of how many people died in 2019, 2018, how many new infections occurred, but we'll only be able to speak with certainty what the prevalence is at this point in time after December. There was a question, Chair, about the HIV mainstreaming, and whether we have an idea of how the districts are implementing. Chair, as the DG presented earlier, HIV mainstreaming, once fully rolled out and well implemented, will be one of the mechanisms that we get additional funding for HIV interventions. We have been working with other government arms, especially Ministry of Finance, which has issued budget calls such as to all the MDAs to ensure that every year they put an allocation for HIV interventions. In addition to that, Chair, Uganda AIDS Commission and partners developed the guidelines for HIV mainstreaming, which interventions should this money be spent on. And the guidelines were launched by His Excellency the President in 2018. So the resources are being allocated, the guidelines are out there. I think what we are seeing as a gap is for us to vigilantly follow up and be sure that these resources are being used for the right activities. We have developed a rollout plan. We will be following up with all the MDAs, including districts, and further orienting them in these guidelines, but also use the opportunity to establish the challenges that they face. Further to that, we have engaged the Ministry of Finance to create vote outputs for all the sectors, so that we are able to capture specific reporting regarding HIV, expenditure on HIV interventions. So we think that with all these measures, and of course continuous follow-up, we'll be able to ensure that the resources allocated are put to good use.
Actually, DG, before that question comes in, there was something on transitioning away from PEPFAR-funded support for ARVs at private for-profit health facilities. Kindly give us some light on that.
The approach of government of Uganda previously has been for HIV/AIDS patients that you seek support and care from the nearest facility, whether public or private. For of course, in the categories of facilities we have in Uganda is that you have public facilities or government facilities, because public is, interpreting that is a little complicated. You have government facilities, you have private not-for-profit facilities, and then you have private for-profit facilities. Now, the ARVs to the government facilities are distributed by national medical stores. The ARVs into the private not-for-profit facilities, mainly the hospitals run by the missions like Rubaga and Mengo, are distributed by joint medical stores. And then the ARVs to the private for-profit facilities like International Hospital, like Nakasero, you can still go there if you're an HIV person living with HIV and get ARVs free of charge, but distributed through a private contractor, was previously called Medical Access, and that was the case. Now, an analysis has been done, and then the funding would come in, the funding streams would come, the money from government of Uganda, the money from PEPFAR and any other donors, it is put in the basket and distributed. And largely, you know, the efficiencies of distributing ARVs through private facilities were found to be, the cost was very high. And the decision was made by the Ministry of Health, seated with partners, that let us carefully refer the patients who have been accessing ARVs through private facilities to the nearest either government facility or PNFP. The process, as USC, we've been receiving some of those questions from private facilities that we see our supplies of ARVs coming, our patients are coming, and we don't know what to tell them. I've channeled this communication both to the Ministry of Health and the PEPFAR colleagues to make sure that it is the responsibility of government, of course, to ensure that communication is done so that, you know, the doctors in the private hospitals can tell patients that because of, you know, efficiency measures, because you may find that by a patient going to seek care in a private hospital clinic, the cost would serve 2 more patients instead of 1. So it makes sense, but an explanation has to be made. So I am sure we are also careful as USC not to go grabbing everyone's mandate, because you weaken institutions if you don't let them do what they are supposed to do. And this communication is supposed to be done by Ministry of Health. I think we'll get back, and I've been in touch with the program manager of the AIDS control program. If that hasn't gone out, I'll go back and see that, you know, efficient communication goes out in relation to who is seeking care where. I don't know, Chair, if that is satisfactory to your question.
Thank you, Chair. On the question of the decline in funding, it was right to observe that there is a decline. From the figure we have from 2018, 2019, and then 2019, 2020, Chair, actually the figure we have here is only from 2017, 2018. But before that, the amount was 10 billion, which was coming in. And then from that, you can see in 2018, 2016 means 17, 18, almost. I mean, we had only 890. And then there was some slight increase. As you can see, it was mainly coming from the Global Fund and then UNAIDS, which again also is coming down. As you're aware, there is some kind of donor fatigue as well. As they give money for HIV, they have been giving, and now their thinking is basically that the domestic funding should actually take over. And even in their priorities, much of their funding now, they look at the health as a whole, not as HIV. So that's why even the amount of money that is coming to HIV will continue to decrease as they look at the bigger picture. And here, that is the very reason why we are talking of sustainability, and we are talking of increasing the domestic funding. If you look at the the issue we highlighted here as the aid trust fund, and then the mainstreaming, all these are geared towards the government putting in much more money and also having this innovative way of raising funds. Because other than that, we cannot continue relying on donor funds. So basically, that's the reason why we are putting in these strategies to have more domestic funding. Thank you.
Chair, also if I can add to that. When somebody else is funding your needs, they determine your priorities, and it makes it very difficult. Like, you know that we've gone, when we went out with you on the presidential fast track, in Isingiro, you saw the community lined up. The chair here actually called the community and said, let's have some public testing. And the donor who has been funding test kits has a very specific policy around how to use the kits. So we are doing advocacy around, we need, because as government, we still have an overall policy around voluntary testing, counseling and testing, and anybody who wants a test should walk into a facility. But because of efficiencies, you know, you also allow somebody to say, if I clearly you do not present a risk, and we've been having conversations on this.